Professor Guri Rørtveit will talk about health registers and general practice. Guri Rørtveit is a professor of general medicine and head of Department of Global Health and Primary Care. So, please, entertain us for the last half.
I will try, thank you. I can tell it's getting late, yeah. First of all, thank you for inviting me, and I will just give you a little bit of background for why I'm here, because I have been a part-time general practitioner in Norway for more than 20 years, and also my research for less than 20 years has been mostly based on registries and cohorts. So those two perspectives will be the basis for my presentation. And it is really a two-way story. And I will ask these two questions to follow us through this presentation. How can health registries lead to research that is relevant for general practice, for the clinicians and the population? And how can general practice generate data that may be useful for research and planning for policymakers and so on? Because these two go together very well in many ways, but it's not the data are there, but they are not used, and I will show you how. And just to clarify that when I talk today, I will talk about all sources of available data, such as the central health registries, the medical quality registries, the administrative registries, and the population studies or cohorts. And of course, these sources do have data that are available for research, but they are under different legislations, which makes it a bit difficult when you want to access them, as we have discussed this today. So the first question is, can research based on registries at all be relevant for general practice? And the answer to that is, of course, yes. And we have a number of research papers based on registries that are relevant to general practice in Norway. And the topics are such as COPD, cancer, prescriptions, and so on, that are all highly clinically relevant. And also, as you can see, some of the papers are being published in high-impact journals such as BMJ and the New England Journal of Medicine, which means that it's not only relevant to general practice, but it's actually relevant for the medical community at large. And these are just some examples, of course. The most used registries for general practice research are actually not the Central Health Registry, which will be marked in red in my list here. CUR is an administrative database based on GP billings, and that will be a very central part of the upcoming primary care registry, KPR, which I will tell a little bit more about after. And that database is used for quite a few research papers from our community. Then the Norwegian prescription database is very important, and that is a central health registry in Norway. After Trygd, the social security data are administrative data and are being held by the Statistics Norway. Fastlegedatabasen, the GP database, is a database to tell us about the GPs, the age, sex, if they are specialists, and so on, how long they have been working in, and so on and so on. Also, we use the cancer registry, the medical birth registry, cause of death registry, Norwegian patient registry, and the registry for infectious diseases. But not as much as the first ones that I mentioned. And we do not have any quality registries in Norwegian primary care at the moment. So as you can tell, we use quite a lot of administrative databases, which means that the access to clinical data is less, and especially we really miss valid clinical data. And I will get back to that too. We do have diagnosis in the CURE database, which is extremely important, but the validation has not been done, and these diagnoses are used for billing purposes. So we don't really know how well they work. But as primary care physicians, many of us, we know quite a bit about how they are being used in practice. And so I think as a community, a research community, we tend to avoid the pitfalls that are possible in this field. But I would warn from using it without respect for that they are being used for administrative purposes. It's not, the diagnoses are not set to for research purposes. So we really long for a primary care registry with clinical data. So the second question is, can general practice generate data that is useful for health research and planning? Is anything interesting going on in general practice? And I have to admit, I'm a little bit surprised that this issue hasn't been addressed previously today, as long as I've been here at least, because there are enormous amounts of data from general practice, and that goes for all of the Nordic countries. It's a big deal for our healthcare systems in all those countries. 14 million consultations in Norwegian general practice are being held annually, with a population of 5 million people. 70% of the population see their GP in 1 year time. And an additional 1.4 million consultations are being held in out-of-hours services, legevakt in Norwegian. And these are all first-line unselected practice with gatekeeper function. And the gatekeeper function is extremely important for all of the Nordic countries, and means that actually most of what's going on clinically in Norway is going on in primary care. Only 10% of consultations lead to referral to secondary care. So if we really want to know what's going on in the healthcare system, we cannot avoid primary care. But I do admit that it's difficult. Today it's very difficult to get access to data. I'm the first one to say that. And that's why we have to do something about it. Also, it's important that Norwegian GPs were early uptakers of electronic medical records already in the beginning of the 1990s. And that's the same in Denmark. I'm not sure about Finland and Sweden. But that means that the use of EMRs among Norwegian general practitioners is very mature. It's very ready for transfer to primary care registry. This is also to show that what's going on in primary care is of high relevance should be of high relevance to all of us, because it's not all about common cold. A lot of people have chronic illnesses, as you all know, and that's mainly taken care of in primary care. And this is from a study in Lancet, which has data from Scottish primary care, and Scotland is quite similar to Norway, where you can see that from the age of 50 or so, the number of chronic diseases increases enormously. So that means that in primary care we have to deal with different illnesses simultaneously, which is different from many times from what's going on in secondary care. So the primary care registry, KPR, that is about to be launched in Norway, was the legislation was in place in July this year. And the main aim is to obtain data for planning, management, funding and evaluation of primary care, whereas the secondary aim is to obtain data for quality improvement, statistics, prevention, security analysis and research. And I would really like research to be a primary aim, but that didn't go through. They never listened to me. But at least research is mentioned, and that's very important. The primary care registry will initially be based on two administrative databases that currently exist. And I have mentioned the CURE databases. the Cure database that we use a lot for research purposes. EPLOS is register for an administrative registry for the care sector of the municipalities, and it's not much used for research currently because it's very difficult to access, and the data is supposed to be not very good quality for research. I never use EPLOS in my own studies, so I don't have first-hand knowledge about it, but my colleagues who have tried tell that that is close to impossible. So EPLOS has to be revised quite a lot to be readily used for research, whereas Cure can be used almost as it is, but it lacks, as I mentioned, clinical data except for diagnosis. And we desperately need a primary care research registry because and needs to have clinical data, because primary care is where the patient is being treated most of the time. And we currently have very little data and very little knowledge about what's really going on in primary care. And I think that's amazing in 2016, how little we know. And it should be scary to many. I have to say, primary care clinical practice today in Norway, I think, has high standard, but we don't really know exactly how good and what's going on. So to a topic that has been mentioned quite a lot during the day, but not for primary care, which is interesting also. Because what we need from the patient registry, I could see I have a different file than I thought I would. We need quality indicators that must be relevant for primary care. And those are not necessarily the same as one would set up for secondary care. So those have to be set up in collaboration with primary care workers. Clinical data from the EMRs must be added to the current administrated data from Cure. Otherwise, we could do just as well with Cure. We don't really need to transfer Cure into a health registry if it's not going to add some clinical data. And very important, I think, and not very much emphasized by many, is that GPs must be trained in correct and consistent use of the diagnosis system. We use ICPC, and I think most GPs feel very comfortable using it, but they use it we are 5,000 GPs in Norway, and I think there are 5,000 individual ways of using it. So it's very important to have some sort of training to get to a more consistent use. And as an extension of that, I think it's not enough. You will come a long way with electronically validated data, but we need also to have the data clinically validated, which in turn implies that we would need a clinical research infrastructure, which we don't have today in Norway, in primary care, that is. And the data must be made readily available for research. And privacy issues must be addressed. And that has been a topic all day, and it's very reasonable. But we do have, there is a recent example from Denmark, which was not mentioned previously, and I think, I don't know all the details, but the sense is that a lot of data has been retrieved from Danish general practice over the years and used for research, many research projects and linked to other registries and so on. And at the end of the day, it turned out that the legislation was not in place, and they actually had to erase a lot of data from general practice. And that's only 2 years ago. And that story, one thing is it's a catastrophe for research in Denmark, but it's also a sort of a catastrophe for our upcoming primary care registry in Norway, because this story is very well known among Norwegian GPs. So we have to do a lot of work to create trust around a new primary care registry. And also the last point is that, as you've all mentioned, access to data is difficult. This is an editorial that I wrote together with a colleague in the Norwegian Medical Association journal just recently about how difficult it is to get access to data in Norway, and how long time it may take, and how the finances just run out, and so on and so forth. And we really have to do something about that. And there is a Norwegian expert committee working on the case, and hopefully before we have the primary care registry, we also have good access to data. And the stories from Finland with and also Denmark about the one-stop shop were really promising. That shows that it is possible to have that kind of access. And with that, I think I will stop, and there might be some questions.
Thank you very much. This was, in my view, extremely interesting. And it reminds me of one fatal flaw in the Norwegian healthcare system, and that is the division between several layers of administrative levels, which I think is, it's not promoting what we want to do with our health data and other healthcare issues. But there must be other questions for you.
Thank you very much. And we have just started, or trying to start, to use Guri data, so I'm glad you say that it's very useful. I thought there was some registry on diabetes based on data from general practice.
Very good example. It's a nice point. And I saw that there was a Swedish, I think, diabetes registry as well. And I was thinking, is there any data from primary care in Sweden in that registry? I wonder. Anyhow, we have a diabetes registry that is based in primary care in Norway, but the data are not good. And the reason for that is that it has been consistently difficult to deliver data. There have been technical problems and so on. It's not part of the regular clinical, it's not what you do all the time. So then you have to deliver data separately, and that whenever the technical solutions are difficult, you just stop doing it. As a GP, I have really tried to deliver data. And I know for sure it can be difficult sometimes. So that registry is not complete at all, as far as I know. I don't know the details about it, but I know it's not complete, and it's far from it. And we would, of course, diabetes is such an important chronic illness for primary care physicians, so we would really like to have those data, but we haven't been able to do it in a proper way yet.
Any other comments?
So thank you very much for a nice speech, and it's very cool to see the general practice registries up and coming, because the other registries in Norway, for example, the Norwegian Patient Registry and the Norwegian Prescription Database, for example, they are made up of data from patients who swing by the hospital, and they are out. And as you said, the general practice doctors, they see their patients year after year. And another advantage in general practice is that you can, technically, you can say you can give money to the doctors for doing special tasks, right? And one of the huge things in modern epidemiology, and at least that's the way I see it, is that we can't really adjust for very important variables like smoking, alcohol, obesity, and so general practice also has this huge opportunity to gather all these baseline variables, so which again could come over to all the other registries, which would be a unique opportunity, if that was understandable.
Thank you for the comment. I think that it's a very important task that you bring up, because it's sort of in line with the diabetes comment, because this is about you're asking for data that are not strictly registered in the electronic medical records. So what we need, and that's one of the reasons why the diabetes registry is not complete, is that it's based not on structured data, but you have to fill in by yourself. Whereas the upcoming primary care registry will be based on structured data, and I think that is key to success. It has to be something that is filled in anyhow. And there are a lot of clinical data that we will be able to access that way, but smoking and alcohol drinking are actually not among them. And I totally agree that those two variables would be extremely interesting to have, but currently there is no way that that is completely registered in Norwegian EMRs.
All right, if there are no more questions, then it's the chocolate talking. Well, thank you very much.